Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 102, Shoulder Dystocia. So after some more reflective topics and conversations with others, I thought this week I'd return to a bog standard clinical topic. Partly because in my brief Twitter poll that I did for my 100th episode, many of you said you like clinical topics. Today I'm going to talk about shoulder dystocia. It's one of those emergencies that I mentioned in episode 79, Help. It's one of the things that we might pull that emergency buzzer for, and we all might rush to try and resolve. So, let's start. What is shoulder dystocia? Its definition is that we may need to do additional manoeuvres to help the woman birth her baby. There may be a delay between the birth of the head and the birth of the shoulders. This can be harder to define than you might think, because with any baby's birth, the head delivers, and then before the shoulders can come through the pelvis, the shoulders have got to rotate, and we call this external rotation and restitution. I talked about it a bit in one of my early episodes, balance. Shoulder dystocia happens because the anterior shoulder, that is the shoulder that's at the front of the woman's pelvis, gets wedged behind her pelvic bone, or the pubic symphysis. If we understand this, then we can understand a bit better how to treat it. Part of the problem with shoulder dystocia is it can be a bit unpredictable. There are things, it's true, that make the chance of shoulder dystocia more common. One of the major things we think about is having a big baby, and particularly a big baby in the context of maternal diabetes of pregnancy. And I've talked about this in my episode, Big Baby. Often, however, it's unpredicted. We don't know the baby's going to be big, or the baby isn't particularly big, but there's something about the labour itself that means it's more likely to happen. Some of the factors that make a higher chance of shoulder dystocia, such as having an assisted vaginal birth or a slow second stage, that is the pushing phase once the cervix has fully dilated, are so common that it's very difficult to anticipate the problem. Because whilst these factors are very common, shoulder dystocia actually only occurs in around 0.7% of vaginal births. So how can we pick out which births it might be a problem from those where it isn't, but some of those other factors are present? Why is it important, and what delay is important? If the baby's head has been born and the shoulders are wedged behind the pelvic bone, the rest of the baby can't be born. The baby can't properly expand its chest and start breathing and adapting to life outside the womb. But equally, it's not getting the blood supply through the umbilical cord that it was when it was in the womb, because the umbilical cord is compressed between the body and the woman's pelvis. Therefore, one of the risks of a shoulder dystocia is shortage of oxygen or hypoxia. How many minutes we have to get the baby out will depend on what condition the baby was in to start with. If this baby had coped well with labour and was in good condition before the birth of the head, then actually we've got quite a few minutes. Whereas if this baby was already compromised, already struggling, it's starting from a lower baseline, and a shoulder dystocia in this situation could result in significant damage to the baby. And the damage we're worried about, if we're not doing something to help the baby birth, is damage to the baby's brain. Aside from the baby being distressed and the hypoxia, shortage of oxygen, babies with shoulder dystocia can experience other injuries. The one we really hope to avoid is something called a brachial plexus injury, or BPI. This occurs because there is stretching of the nerves in the brachial plexus. The brachial plexus is the bunch of nerves that come out of the baby's neck and supply the arm. Stretching of these nerves excessively, sometimes due to us as practitioners perhaps pulling on the baby's head to try and release that shoulder, can result in damage. Fortunately, most of the time this damage is short-lived and may be easily corrected with physiotherapy. But in some cases, this damage can be permanent. The other complication that can sometimes occur for a baby is a fracture of a bone, a fractured arm or a fractured collarbone. And again, babies are very resilient little things. This will usually heal very well. The baby will be given some painkillers, some physiotherapy and some follow-up. Mothers can also experience complications and problems from shoulder dystocia, one of the most common problems being a bad tear and therefore excessive blood loss. I hope that these descriptions haven't scared you too much, because what I'm going to talk about next is how we treat shoulder dystocia. We are well aware that for both mother and baby, this is an emergency situation where time is of the essence, and we need to be careful in doing the right things to relieve the situation and free that shoulder so that we don't cause more harm than good in our actions. Sometimes we can anticipate a shoulder dystocia might be going to happen. Maybe we know it's a particularly big baby, or as the head is born, we get what's called a turtleneck sign. So the head comes out, but not completely. Maybe the chin doesn't come out and emerge properly, and therefore it looks like the baby's wearing a polo neck or turtleneck sweater. If we anticipate this problem, we may start doing some of the things that might help relieve the shoulder dystocia before we've even decided if it's going to happen. Taking preventative measures, as it were. Training for shoulder dystocia is something we do on a regular basis. It's a key component of our annual mandatory training update as obstetricians and midwives. We can click into exactly what we need to be doing. And we have a little mnemonic to help us on our way, help remind us what are the steps we should be doing. And the mnemonic is helper. So let's start with H. H stands for help. We need help. We need to pull the emergency buzzer if we haven't got lots of people there to help. If we have got plenty of people, we might be calling the paediatricians if they're not already present. Help. We need more pairs of hands, essentially. We'll be pulling that emergency buzzer, and we may be putting out the 2222 obstetric emergency bleep. We will probably say to the woman, We're just going to get in some extra people to help with the birth of your baby, and we're going to move you into some different positions to try and help your baby come out safely. There'll be a flurry of activity for people coming into the room. The next thing is E, evaluate for an episiotomy. It's actually not easy to make a cut and do an episiotomy once the baby's head has already been born. And given that we said the shoulder is actually stuck behind the pelvic bone, making a cut in itself is not going to release the shoulder. But it might give us space to safely do some of the other manoeuvres that we may need to do to assist the baby out without doing too much damage to the woman's pelvic floor and perineum. So E stands for evaluate episiotomy. Next we have L. L stands for legs. The first thing we're going to do is put the woman in what we call McRoberts position. This will involve 2 members of staff, and we'll tell the woman what we're going to do as we're doing it. We're going to lie her flat, so put the back of the bed down, extend her legs out long, and then bend them and bring them up so that her knees are coming towards her shoulders. This is called McRoberts position. It will help open up the pelvic outlet and give the baby a bit more space. If this doesn't work, we move on to P. This one's a little bit of a gimmick because it stands for suprapubic pressure. Whoever is helping with the birth will identify which side the baby's back is. And then another assistant, midwife or doctor, will apply suprapubic pressure from behind the baby's back. This is a bit like doing CPR that you see in the movies when someone has a cardiac arrest. It's the same sort of hand position, and we can either apply it constantly for 60 seconds, or often what you'll see us do is exactly like CPR, rock for 60 seconds. And what we're trying to do is get the baby's shoulder to rotate and dip under the pubic symphysis, under that bone that's blocking it coming down the birth canal. To a woman, this may feel quite traumatic. We've suddenly flung her legs back in the air, there's lots of people in the room, and then someone is pounding on her abdomen just above her pubic bone. Although this sounds very dramatic, most shoulder dystocias will actually resolve with these 2 measures. More than 80% of cases, this will free the baby. So if we can communicate and explain to the woman and her birth partner what we're doing, why we're doing it, in a calm, quick manner, we're going to ask some extra people to come in and give us some help, and we're going to change your position and move you around quite a bit and press on your tummy to help release your baby and help your baby on its way. Don't be frightened. This is something we all train to do. So those 2 measures are our go-to. I'm going to pause here a moment because actually, if you're at a home birth or a birth on the midwifery-led unit where a woman isn't necessarily lying down, often what we'll do is actually get the woman to roll over onto all fours, because that will often dynamically change her pelvis and release the baby. Or if she's in a birthing pool, actually moving her hips apart to step out of the birthing pool can also often help release the baby. So although these steps come further down the helper mnemonic that we're traditionally taught, the order in which you do some of these manoeuvres may not follow that exact script. It will depend on whether you've got a woman who's completely mobile or whether you've got a woman who's bedbound with an epidural and heavy legs. Now we've got to E. Enter. This is about trying to do internal rotational manoeuvres. So we've tried suprapubic pressure, pressing on the woman's abdomen to dislodge that shoulder. Now we're going to put our hands in the vagina and press either side of the baby's shoulders to try and do internal rotation. Again, we're trying to rotate that shoulder away from the bone that it's stuck on. This can be very difficult to do. It's very tight. There isn't a lot of room to get your fingers in the vagina alongside the baby. The manoeuvres are done in two different ways. One is called Rubin 2. This is putting the fingertips behind the anterior shoulder and trying to rotate it forwards towards the baby's chest. This is so-called Rubin 2 because Rubin 1 is the suprapubic pressure. This is an internal version of the same manoeuvre, trying to push the anterior shoulder forwards. Wood screw manoeuvre is using the fingers of the opposite hand approaching the posterior shoulder, so that's the shoulder at the back, from the front of the fetus, aiming to rotate that shoulder up towards the pubic bone, the symphysis. Again, we're trying to push the baby's shoulders through 180 degrees like a thread on a screw, and thereby release the anterior shoulder, which is the one that is causing the trouble. Reverse wood screw is the opposite. So you place your fingers on the posterior shoulder from behind and try and rotate in the opposite direction. So all these internal rotational manoeuvres can be tried. As I said before, the strict order in which you practice manoeuvres, once you've done the suprapubic pressure and McRoberts position, depends on the individual doctor or midwife, how they feel most confident at managing the situation, and also how mobile is the woman and what position she's in. The final bit of helper is a little bit of a trick because it's RR, two R's at the end. The first R is to roll the woman over. Roll over onto all fours. And I've mentioned this earlier because midwives will often use this much earlier in proceedings if they're at a home birth or the woman's very mobile. If you imagine this, immediately flips everything upside down. So the anterior shoulder, which is stuck, is now at the bottom and the posterior shoulder is at the top. And gravity, as well as a change in the diameters of the pelvis with this movement, may allow the baby to be born. The other R stands for remove the posterior arm. So if you can get your hands into the vagina, you have to feel your way up towards the elbow of the arm that's at the back. And this is because there's more space in the pelvis at the back than there is at the front where the shoulder is stuck on the symphysis. You feel your way up to the elbow, bend or flex the forearm and sweep it down across the baby's chest. That releases the posterior arm, brings the posterior arm down through the vagina, and then that in turn releases the anterior shoulder and undoes the blockage, as it were. This manoeuvre can be very successful at delivering the baby, but this is the manoeuvre where, if done with difficulty, this can result in fractures, particularly of the baby's humerus, that's the upper arm bone, or the clavicle, the collarbone. But for many shoulder dystocias, difficult ones, removing the posterior arm actually results successfully in the birth of the baby. What if none of these manoeuvres work? As I've said, the clock's ticking, time is moving on, and we're worried about the lack of oxygen for the baby. So if we've gone through all these manoeuvres, we will go back to the beginning and start them all over again. But there are some other extreme moves that are written about in the textbooks that most of us obstetricians have never performed or seen performed. They simply aren't practical or have significant consequences. The first is something called the Zavanelli manoeuvre. This has the idea of trying to reverse the progress of birth, so reflexing the baby's head and trying to push it back up the vagina into the womb so that we can perform a caesarean section. This is fraught with difficulty. Everything the womb and the baby have been doing up to this point and the contractions are moving in the opposite direction. So potentially we can traumatise not only the baby with fractures of the skull, but also the womb. We can tear or traumatise the vagina, and we can cause a rupture of the womb, causing a woman to lose a significant amount of blood. Most of us as obstetricians know, even when the baby's head is low in the pelvis and has not been born, it's very difficult for us to perform a caesarean at that late stage of labour. And I think this is why, although it's reported in the literature, the Zavanelli manoeuvre is something most of us have heard of but wouldn't dream of actually trying to do. In practice, extremely difficult and likely to cause complications. The other very drastic option is something called a symphysiotomy. And this works on the principle that the pelvis just isn't quite wide enough, and that if we actively could cut the pubic symphysis, the join in the front of the pelvis, and just open up that joint, that would help the baby to pass. Again, this is something I have never done in my career or seen my colleagues do. But it is something we're taught in simulation, to give local anaesthetic and cut the joint in that bone. It's something that used to be done much more frequently before the era of much higher caesarean section rates and much safer anaesthetics for caesareans. Having these extremely rare, drastic treatments listed in textbooks can cause problems. For me, shoulder dystocia has always been absolutely imprinted in my mind because of what happened when I was taking my membership exams of the Royal College of Obstetricians and Gynecologists. I went on a very well-respected Part 2 revision course. And part of our exams is to do something called OSCEs. These are simulated clinical exams. And in my practice, in my Part 2 revision course, I had a mock OSCE, a simulation of shoulder dystocia. I did all the normal manoeuvres. This was with a mannequin and a doll. I was talking through to the examiner about what I was doing and why. At the end of the scenario, I was quite aggressively questioned. What else would I like to do? What else? I got the feeling that I'd left something out, and I couldn't think what it was they wanted me to talk about. I hadn't mentioned the Zavanelli manoeuvre, but surely they didn't expect me to do that. Although this was a very good revision course, I must admit that this particular event was a little bit teaching by humiliation. I was up in front of the whole group that were on the course, on the stage, and being chastised and taken through exactly what I should have done for shoulder dystocia and how I should have mentioned and discussed the Zavanelli manoeuvre and symphysiotomy. I was actually really quite upset. I didn't feel it was realistic treatment. And why would you say an exam, something that you would never entertain? But I took my medicine, as it were, and I went home and I revised shoulder dystocia, and I thought long and hard about what I should say. Imagine the dry mouth moment in my real part 2 exam a month or 2 later, when, lo and behold, what was my actual, real, genuine OSCE situation? Yup. Shoulder dystocia. My heart sank. I absolutely knew it inside out. But there was that doubt in my mind. Oh my God, do I mention the Zavanelli manoeuvre? Do I not? Do I discuss it? What do I do? I confidently launched into the shoulder dystocia, and actually the examiners were much more friendly and much more encouraging than my mock OSCE had been. And I got through to the end and discussed everything, and I did briefly mention the Zavanelli manoeuvre, at which point the examiner slightly laughed, and I did have a reasonable explanation and conversation about how, of course, this was an option, but that there were pros and cons, and that it is rarely, if ever, performed. So I felt in the actual exam I had been able to put it in the correct context. But that experience means for me, shoulder dystocia absolutely drummed into me, unbelievably, never to be forgotten. So I don't know if that's good, contributes to my skill set and experience, or bad. It can be debated. As I mentioned earlier, one of the key things when the baby's head has been born and we're experiencing difficulty with the shoulders is the importance of not pulling too hard on the baby's head and stretching those nerves, that brachial plexus of nerves that supply the arm. Because it's that pulling and stretching without releasing the blockage of the shoulder that causes those brachial plexus injuries, which happen in 1 in 10 babies with a shoulder dystocia. For this reason, we practice shoulder dystocia in our training year in, year out. And at one point we did have a mannequin to practice on that actually had a strain gauge. So it measured, when you were pulling on the baby's head, how much pressure you were putting, and therefore how much pressure you might be putting on that brachial plexus, on those important nerves, so that you could understand how much pulling was safe, because you do need a little bit of traction, pulling to release the baby, but not excessive force. So with a shoulder dystocia, we practice every year, year in, year out. We're well versed in what we should be doing, and we know that 80% or more of shoulder dystocias will resolve with those first manoeuvres, changing the woman's position either to McRoberts or rolling over, and the suprapubic pressure. What if you've had a shoulder dystocia? Then what? What can you expect in your next pregnancy? Well, the first thing that's really important is for us to have your birth notes, to know the weight of the baby, what position you were in giving birth, and what factors might have contributed to it. What manoeuvres did we have to do to help release the baby's arm and shoulders? And did you or your baby sustain any injuries as a result of the shoulder dystocia? If it was something actually very straightforward, just moving your position, release the baby's shoulder, and there was no ill effect for either of you, then usually we would probably be recommending vaginal delivery. We might organise a scan to check on the size of the baby in late pregnancy, maybe around 36 weeks. And if the baby seemed large, we may suggest induction of labour. But if the shoulder dystocia was more complicated, maybe the baby had injuries, maybe you had a bad tear, or the whole experience was quite traumatic for you psychologically, or you're expecting a much bigger baby, then we will discuss with you the alternative of caesarean section, because this is the only way to absolutely guarantee that you do not have a recurrence. So during your pregnancy, you should have discussions with staff and be offered both alternative options. But our advice, our recommendations will very much depend on how severe or not the shoulder dystocia was and how you feel about it. Okay, what's my zesty bit? My zesty bit is a little bit odd. I've been thinking about 100 years of progress because that was the theme of the International Day of the Midwife this week. And one of my listeners suggested that I do an episode on that, which I'm starting to plan. So as part of my preparation for today, I looked in my 1930s Glasgow textbook of obstetrics to see what did it say about shoulder dystocia. The result was simply astonishing. There was no mention of it. It was not mentioned in the index. It was not mentioned in the problems in labour. It wasn't mentioned in the instrumental birth section. There's literally no mention of this. And I thought, why? Why would that be that in the 1930s there was nothing about shoulder dystocia? I mean, did it not happen? Did it not happen because women were having their babies at home? Did it not happen because women were more mobile, epidurals didn't exist? Did it not happen because we were doing less instrumental births? Were babies smaller because women didn't have such good nutrition? What is that all about? So one of the key messages, my zesty bit today, is let's think about all the things we can do to avoid shoulder dystocia. So being active in labour, being up and about upright, not lying on our backs. And if you're having an epidural or you're looking after a woman with an epidural, thinking about her sitting upright or birthing in left lateral so that her pelvis has got the maximum flexibility and room to move. Also, when we know a woman has a higher chance of shoulder dystocia, such as she has gestational diabetes, let's pre-warn her. Let's talk to her about if we think this might be a possibility, we may ask extra people into the room. These are the positions we may get you into so that it's not a traumatic event for the woman. So I guess I've got two zesty bits. One is, let's do everything we possibly can to avoid it in the first place. Because is this something of our creation? I don't know. And then secondly, when and if it does happen, or if we're anticipating it happening, let's keep calm and communicate clearly with the woman and her partner exactly what is happening and what we're expecting when people come into the room and why we've asked for their help. And also communicate clearly to the team around us, announcing this is shoulder dystocia and what manoeuvres have you already done. For example, if I'm coming into the room, the midwife might often say, this is shoulder dystocia, we've already done McRoberts, we're about to start suprapubic pressure. And then I know at what point I'm starting to think about the next manoeuvres. If you're a woman worried about shoulder dystocia, I've put some great links in the programme notes. Maybe you've had a shoulder dystocia before, or maybe someone said your baby's a bit bigger than average. Have a read so you can make a well-informed choice. But don't be frightened. Far and away, most women and babies who experience a shoulder dystocia will have a very good outcome. I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Thank you for listening.